Mrs. Anderson. I'm just going to check your airway to make sure it's all clear, alright? So I'm just looking in the airway for any secluded objects or vomit or blood. Thankfully this patient's conscious, but if they weren't, I would insert either a Goodell or a nasopharyngeal airway just to ensure the airway remains open. So just to insert a Goodell, you measure from the mouth to the back of the ear. Put it in this way and twist as you get to the back of the throat. If need be, I can use suction to remove vomit or fluid. Now this patient's just started to vomit, so we're going to roll them onto their side, which is called a log roll. So I'll just get my assistance. For a patient with spinal precautions usually requires more than 4 people, so about 4 to 6 depending on the size of the patient. So normally we would have a few extra, but we don't today. So we're just going to roll this patient. 1, 2, 3. Now unfortunately these patients' arms don't move, but normally they would be up on their chest there. Now just to clear the vomit, to get rid of their vomit or sputum, and just to allow gravity to let it come out.
These patients on their back, I'm just going to listen for normal breath sounds. And equal air entry was heard on inspiration and expiration. Now we can roll the patient.
1, 2, 3.
Okay, I'm just checking to assess if the patient is breathing. I'm checking for general respiratory distress, which would be work of breathing, shortness of breath, or the use of accessory muscles while they're breathing. Now, Mrs. Anderson, are you having any difficulty breathing at the moment? And the patient is replying in full sentences. So now I'm checking for the respiratory rate and depth, and rhythm to assess for any underlying problems. If the respiratory rate falls below 12 or goes above 20. Now I'm feeling for chest deformity and movement. Mrs. Anderson, I'm just going to put my hands on your chest for a minute. The chest should rise and fall equally on both sides. Abnormal movement or shape may indicate a pneumothorax or a hemothorax. I'm just listening now for external breath sounds, such as a stridor or a rattling sound, which indicates secretions in the mouth or the airways. I've already listened to the patient's back whilst she was on her side in the log roll. We don't want to do another log roll just because there's the spinal precautions and to save time. She's got a SATS probe and her SATS durations have fallen to 88%, so we know that her oxygen, the blood isn't being oxygenated, so we are going to put some oxygen on to the patient. Mrs. Anderson, I'm just going to put some oxygen on. This will help you with your breathing. I will put that up. This is via the Hudson mask, and it will go from you'll start off with 6 litres to see how the patient tolerates that. Valve device, and it would be attached to high flow oxygen. It just sits on the patient's mouth.
Other way.
That way?
Yeah.
And is pumped like so. Or you can use a laryngeal mask, and the patient could be intubated.
You will check the peripheral pulses. If the pulses are weak, you check the pulse in the carotid. Note the location, quality, regularity and rate and rhythm of each pulse. If the pulse is absent, commence basic life support or advanced life support. You check the blood pressure. Low blood pressure can indicate shock, along with tachycardia. High blood pressure can indicate stress and anxiety as a result of the trauma. For this patient, I will put cardiac monitoring on and apply direct pressure to any external bleeding. I would put IV cannulation into both the arms.
I'm doing disability and exposure. For disability, I'm going to take note on whether the patient is awake, has a verbal response, a painful response, or is unresponsive. My patient is awake today. I will not be conducting a Glasgow Coma scale as this is only a primary assessment and a GCS will take too much time. And straight away, looking at my patient, I'm going to notice whether my patient is in a coma or not. For exposure, I'm going to undress the patient, starting from the top half and then the bottom half, remembering to try and keep the patient warm at all times. So Mrs. Anderson, I'm just going to uncover your dressing gown now to have a look for any external injuries. And now I'm going to remove the sheets to check your legs. The patient does not have any external injuries. If the patient did, I'd have to document those findings. I checked the back of the patient when we did the log roll, saves time and not moving the patient as much.
How do you reckon you went, Sarah?
Yeah, my part was pretty complex. Well, with the log roll, I thought we could have used a lot more people. It felt very unsteady. And then at one stage, I let go of the patient to suction their airway. And obviously, we wouldn't do that if it was a severe case, a real situation. And when we did the log roll, we definitely should have covered the patient's private parts. We didn't think about that. And at one stage when I said the patient was spewing, we all had to come in and we like slowly rolled them, but we should have been there straight away rolling them so they didn't choke.
So how do you think you went with it?
It was definitely a challenge, and I think when I was listening to the chest, I needed to listen for a bit longer. But then it's sort of hard because the patient was breathing, but you still need, to assess them further. But because it's a primary assessment, it needs to happen really fast, and it's hard to know how much time that we need to, allocate to each part within our parts. Because all of our parts have like several things that we had to do for them. And I think I skimmed over a little bit too fast with the listening. And also when putting the oxygen mask on, I needed to probably explain a bit more what that actually does. Like with oxygenating the blood in the cells to help perfuse, organs and stuff, rather than just saying, "Yeah, I'm putting oxygen on you to help with breathing." I mean, you could probably explain it even better to the patient, but you wouldn't necessarily have to say the strict patho of it because they probably would have no idea what you were talking about. But how did you go?
I think it was alright, but like being the first time that I've ever had to really assess someone's circulation, like in that situation, I really thought that I would have been checking like the pedal pulses and stuff for a bit longer, like it was just trying to be quick, and I might have used like a Doppler. If primary assessment, you got to do it quick. But yeah, like I would have taken a little bit longer, like feeling for it. And if I couldn't, find it, I might have either moved on or quickly got another nurse to try and help me out. And I really should have talked to the patient. Like I was touching their feet and their hands, and like they're probably scared, probably anxious, and I didn't reassure them enough. Like focus on enough, like would.
Yeah, it was the fractured pelvis.
Yeah. So yeah, we didn't address it when we were doing the log roll. Like we didn't take any precautions. Like we would have rolled them on the opposite side to the fractured like pelvis, and even when we were like assessing for exposure, like that sort of side of thing, like we didn't mention anything about it.
So what do you think? How did you think you went?
I thought that I didn't cover enough within my film, even though I probably did. Like I felt like what I did wasn't enough. Like even though it probably was like enough. I think I needed to talk to my patient a little bit more, and like even though it was hard talking to a mannequin, I think that I sort of assessed it like there was nothing wrong with my patient, even though after a car crash there should be. Like, there would be like bruising or swelling or, you know, some minor cuts and bruises. I didn't really mention that in the film.